All right, don't curse or anything. We got we're, we're live recording, and we'll get started in just a minute. Let's see. All right. Hello everyone. Just a couple housekeeping rules. We will be doing a little bit of a presentation. Teresa's going to kick us off in a second, but please use the chat function to put in your questions or comments, and I'll be happy to cue the docs for those, especially if you have questions about the content on the slides. We will also do our best to save time for Q&A and discussion. But again, feel free to put in your comments and questions into the chat in written form. I appreciate that. And do your best to stay muted so we uh, avoid too many background noises. Um, well, it's Tuesday and it is 8 o'clock and you are all on time. So, Teresa, how do you feel about getting started?
I think it's probably okay, but let's just wait till 8:01.
Okay. All right, sounds good.
You may have to repeat the rules again after I do the intro.
Sounds good. Hey, our old friend AJ is joining. Wonderful.
Yeah, few familiar faces and people. Great.
Oh, look at that. Oh, you were right to wait to 8:01. Look at that. They're all hopping on.
All right, are we ready? I think we should start.
All
Yes?
right. Yeah, Teresa,
Okay,
you
great.
are the boss. Take it away.
So good evening and maybe good afternoon for some of you on the West Coast. It might still be the afternoon for you. Welcome to Physicians Research Center's first Cerium Journal Club. We're happy you're here. Physicians Research Center is a company that started back in the mid-1990s as a clinical research center doing phase 2 through 4 clinical trials. And it's evolved the past few years, adding a network of physicians and researchers to our research pillar now is named SALIS, Cerium, which houses our educational programs, and Buds Info, our analytics pillar. You can check out our website if you want to learn more at prctrialsplus.com. We have a number of partners that we work with on education and data collection projects. If you stay till the end, you'll have the opportunity to learn about our most recent project. Tonight, we're going to be talking about cannabinoids and rheumatic diseases. And to start that conversation, we have Dr. Len Kamen from Jefferson University, Phil Malloy, who's newly retired from his clinical practice, but still works in a lab in the Massachusetts area. And each of them have greater than 40 years of clinical practice. And Dr. Jehan Marcoux will be kind of like our moderator with them, a renowned cannabinoid researcher. I'm going to turn it over to Dr. Marcoux to start the conversation. Over to you, Jehan.
All right. Thank you so much, Teresa. So welcome to the Journal Club. Today we'll be discussing this article entitled Cannabis and Rheumatoid Arthritis, a scoping review evaluating the benefits, risks, and future research directions. So as you can see in the bottom, the paper states that rheumatoid diseases are characterized by progressive chronic inflammation of the musculoskeletal system, afflicting primarily the joints, but can lead to systemic comorbidities such as pulmonary disease or vasculitis. It is a chronic condition that can result in chronic inflammation, such as cartilage and bone damage, whose further deterioration can lead to the disability of the affected patient. So, the medical costs for treatment, as well as reduced work capacity and decreased societal participation of patients with RA, have a significant socioeconomic effect on society. So finding new treatments is really important. But I think one of the most important things that this paper actually comes out and talks about, I think one of the highlights is that cannabis is not a single substance. If you've been following the news at all and listening to or reading about the HHS recent report, it highlights the variable nature of cannabis, or marijuana as it's sometimes referred to. And the plant is not just a vessel for THC. This plant is more than just a vessel for THC. It can have a lot of things on it, and sometimes no THC at all. So each cannabis plant is this hoard of pharmacological treasures. It can have any number of possible 120 so terpenes on it, ranging from the very light and not so smelly to the very heavy and very loud and prominent smelly things. So it has a huge range of compounds. And then there are the cannabinoids, which are also pharmacologically active, similar to the terpenes. There's a mix of acidic and neutral compounds, primary metabolites, secondary metabolites, artifacts formed through storage. So depending on what stage of the plant and how it's processed, it could have a whole range of what you might call active or inactive compounds. Those are compounds that have, different properties. So you can have cannabis plants that have THC as a predominant compound. Cannabis plants can have other active ingredients that are the primary ingredients. So cannabis is not a single substance. So when we talk about, remember that it is a category. And underneath that category called cannabis is nearly every combination of ingredients that you can think of that occur on the plant. But one important concept is that while we always hear the statement, oh, cannabis has 500 compounds on it, not all 500 compounds occur on every single plant. So sometimes we're only talking about 10 ingredients that are there in any significant amount. Similarly, when we talk about THC, THC is not a single compound, it's actually a class, right? So when we say THC, what are we actually talking about? Well, we're talking about a large category. And I think sometimes it's astounding for me that we can speak about THC with such simplicity, even though it's this huge category that includes delta 8 THC and the several isomers of that, as well as delta 9 and the several isomers of that. The FDA approved Marinol is just one isomer, the most potent one of delta 9. It's not a mixture of isomers like they occur on the plant. So delta 9, delta 10, there's all these designations to where double bonds are in the structure. So there's a huge number of combinations corresponding to these positions of double bonds. So when we talk about THC, we have to start to get more and more specific as we're going to drill down to what is really responsible for an effect. So why do we care about this variable plant and RA? And I think, as the paper points out, it's very challenging to treat rheumatoid arthritis because of the side effects of available therapies. And there's not really conditions known to reverse the condition in totality. So we are interested in these compounds, such as cannabis, because they interact with a system called the endocannabinoid system. So here we have a model of the human brain. We know it's an accurate model because there are 3 functioning brain cells, so it's very accurate. But the important thing here is that it highlights this system that THC interacts with, which is why we care about this, is that it has cannabinoid receptors. And we have endogenous ligands known as endocannabinoids. Here, anandamide and 2-AG are pictured signaling in a retrograde fashion to decrease synaptic transmission. Similarly, we can even drill down further with molecular mechanisms. So we have these compounds that are made that interact on the cell surface with targeted protein interactions. The cannabinoid receptors, which are G protein coupled receptors from the class A rhodopsin family. It's a super family of receptors. There's a lot of them. They come from some of the oldest receptors. They evolved from rhodopsin, which are the receptors that detect light in the eye. So these are really old, evolutionary speaking, conserved across species. And these molecular mechanisms have been really promising in different in vivo models, which have shown their ability to decrease inflammation through these downstream cellular responses. So here are a few examples fun examples maybe. One of the things this review article discusses, for example, is the ability of cannabinoids to modulate the immune system. So if we look at this center sort of diagram here with this TH helper cells, it talks about that delta 9 THC, somewhat specific, suppress the cell-mediated T helper 1 TH1 response and enhances TH2 associated cytokine secretion, which again can be important for modulating many of these things. TNF alpha is a big player, for example, in inflammatory responses. There's also other signaling pathways such as NF-kappa B, myosin activated protein kinase, or MAPK if you spend a lot of time in the lab. There's the JAK-STAT pathways, the Janus kinase and signal transducer and activation of transcription pathways in immune cells that cannabinoids can interact with, that can also help to prevent cartilage damage in cellular models, petri dish sort of models. There's even been some synthetic cannabinoids that have tremendous potency. HU210, developed at the Hebrew University, it's estimated to be somewhere between 100 and 1,000 times more potent than THC, as well as WIN 55212, a compound developed by Sterling Winthrop. These compounds have been around for decades, used in research. They're very, very potent, full agonists. THC is a partial agonist, but they have also shown the ability to prevent matrix degradation, and also inhibit some of the interleukins that are responsible for the breakdown of things like collagen. They also can inhibit some of the nitric oxide synthase and COX-2 expression, as well as NF-kappa B. But again, these are synthetic full agonists that have been used in these studies that have shown some promise. So that was a lot on cellular research, but probably what's also promising is the animal research. And Dr. Malloy, Phil, if you'd like to take over from here and just make sure you hit the magic mic button.
Yes, thank you.
So,
Thank you. If there are any rheumatologists in the audience, you recognize on the previous slide that Jehan just showed some of the cytokines for which we have targeted monoclonal antibodies and other mechanisms of actions to interfere with the pathogenesis of inflammation. We can block IL-6, we can block IL-17, we can block TNF, we can block inflammatory cells as well as the cytokines. So that's interesting. So in order to even get to the question, is the endocannabinoid system evolved in the pathogenesis of rheumatoid arthritis? And is there any foundation for which we can postulate that in our patients, this is a potential therapeutic target? As Jehan just said, we start with animal models. So we'll go ahead 2 slides here. This article is full of references for you. I have chosen to highlight 2 animal models and 2 human models. 2 animal models on this slide. Just a word on them. Reference number 32 for anyone who would like to click the links on this article and get the original papers. There is a rat model of inflammatory arthritis, which is a reasonable model of rheumatoid arthritis. When animals are given endocannabinoids, they have less, these animals in a model of inflammatory arthritis, mostly THC, I believe in this study, there were less inflammatory cells in the synovial fluid in this model of rheumatoid arthritis. Clinically, less inflammation and less joint damage subsequent to this inflammation. So this is an early rat model showing that an intervention based on endocannabinoids or cannabinoids, sorry, has potential to dial down inflammatory arthritis. Reference 35 is a mouse model, very famous model of CIA, stands for collagen-induced arthritis. It's an inflammatory form of arthritis that can be instigated in mice, like being allergic to a certain type of delivering collagen in a way that instigates an immune response in the joints. And in this model, there were less inflammatory cytokines in the synovial tissue, less erosions, and less joint damage following these mice. There are a host of other animal studies that you can read about more, but suffice it to say that there is a list of studies involving animal models enough to suggest, hey, maybe we should look at this in humans. Is this a legitimate therapeutic target that can help our patients? So what have we learned from human studies? We'll look at on the next slide here. So in human studies, let's take a look. There are um, a lot of ways to do this, to conduct these studies. So reference 39 is an ex vivo study that studies synovium. It studies patients, many of which have rheumatoid arthritis at the time of joint replacement surgery, and their synovium, their inflammatory, diseased, inflamed synovial tissue is brought into the lab and studied. First thing that was found is that there's a huge upregulation of the endocannabinoid system and cannabinoid receptors, and that this upregulation and high expression of the ECS, the endocannabinoid system, its receptors and ligands, correlated with the degree of synovitis in these patient specimens. Furthermore, you could block the inflammatory milieu with CBR1 antagonists. So something is going on, and this suggests that it's real, that the endocannabinoid signaling is a real participant in inflammation in these joints. And the conclusion in this study was that the endocannabinoid system is likely to be involved in the expression and even in the pathogenesis of rheumatoid arthritis. Reference 49 is worth putting up here because I don't know if there's any other prospective randomized control study of a cannabis product in rheumatoid arthritis. It's not a huge study. It's a small number of patients. It's a 5-week study. Patients were randomized to placebo or an inhaled product that had equal concentrations of THC and CBD. Multiple endpoints were studied that were clinical in large part, but there are some laboratory components too. For example, the DAS28, if there are rheumatologists in the audience who have tuned in tonight, the DAS28 does include either a CRP or a SED rate. And the short form questionnaires about pain, pain on motion, pain on rest, morning stiffness, and so forth. And there was a small but statistically significant improvement noted in the cannabis intervention group compared with the placebo. It's preliminary data. It's not enough to make rock solid, watertight conclusions, but it tells me as a rheumatologist involved with this space here that we need to do more research with larger numbers of patients and use more standardized outcome measurements in order to see what the real effect is, dose finding studies, and so forth. So those are 4 studies, 2 animals and 2 human, who point us in the direction of, oh yeah, maybe there's a story here that's going to help our patients.
Thank you. And those are just 2 of the studies from this paper. There are a couple panels here. We just want to kind of give you an idea. When we say we selected, just as Phil had, as Dr. Malloy had, there are a number of studies to look at that are exploring different aspects of this, and hopefully we'll talk about in a little bit about related to pain, related to effects, side effects, and as well as looking at different products and in combination. So, Dr. Malloy, we have a question, I think, about the study you brought up
Okay.
Was Sativex added to SOC or SOC or just versus placebo?
Good question. Thank you. A standard way to do rheumatoid arthritis studies is to take a group of patients on whatever they're on and don't change it. So there's a run-in period and their baseline background rheumatoid arthritis medicines are not changed. And they have to have active disease, active inflammatory rheumatoid arthritis, despite whatever treatment they're on. Then they're randomized to a placebo or an intervention from there. So yes, they were on a variety of background medicines.
Excellent. Great question. Thank you. Keep them coming. Here is another example of the retrospective studies that have been included in this review. Lots of good data, decent, I think, sample size numbers, including users and non-users. They also include, I think up until 2021, looking at a number of these studies. And based on questions and feedback from the audience and from our clinicians here, we can go back to these slides. This is not a linear presentation per se. We can come back to these if anyone from the audience wants to discuss them or has questions about them. But one of the things that struck me was, why did people stop using cannabis to treat RA? I thought it was really interesting. So we will see if this lets me pop open a poll. Let's launch it. I hope you all can see this. Please start answering. Why did people, according to this study, right? What is the main reason patients stopped using cannabis for RA? It didn't work at all, no effect, adverse effects, stigma. When I say they ran out of product, I mean like the dispensary or where they were getting it. Or it could mean they just ran out of it, so they never bought it again. They couldn't access it anymore. That was the intent of that question. So the results are coming in. Again, it didn't work at all. There was no effect. There were adverse effects, things they didn't like. The stigma of using it, they didn't like smelling like cannabis, or their kids complained, something like that. Or they ran out of the product either at the dispensary, or once they finished using the product, they just didn't want to keep using it. We'll let the poll go a little bit. I see some numbers changing. All right. All right. Very interesting. So I'm going to close the poll in a little bit here. I'll count down in 5 seconds. In 5, 4, 3, 2, 1. And I'm going to share the results now. Now, most people said adverse effects, and I hope you can see the results. Most people, then second to that was they ran out of the product either at the dispensary or at home, and they just didn't get any more of it. Another one is it didn't work at all, no effect. So what's interesting about what they say in the paper is the main reason was that people discontinued cannabis because of a lack of effect. 28% was, I believe, due to adverse effects. And this is a direct quote from the paper. So I found this to probably be one of the most interesting things to me about this product is that they cited that there was a discontinued cannabis use because of a lack of effect. And getting back to our terminology, I would love, again, as a molecular guy, what do they mean by cannabis? Is that a THC rich product? Was it a CBD rich product? Was it orally administered? Was it inhaled? What are some of the more specifics around that? And I think this is why we keep having to ask questions and do observational work, is to start to drill down on this terminology of what is it people are actually using. We may assume that it's THC rich cannabis, but how are they consuming it is an entirely other question. When we talk about Sativex being effective, that's a cannabis oil extract dissolved in ethanol that's sprayed under the tongue and absorbed mucally. That's an even mixture of THC and CBD, and it's very, very, very rare that people experience impairment or intoxication or high or euphoria from using that product. I think there's been one documented case of a side effect called happiness, as it was classified in that clinical trial, but it's very, very rare. So again, when we talk about cannabis, it's not the same thing as something like Sativex per se. It's not the same thing as a purified THC product. It could be a subcategory, but we don't know. So it would be interesting to see how that shakes out. So as we move along, I'd like to page Dr. Kamen, Dr. Len Kamen.
Yeah, I'm back on. Can you hear me?
Yes,
Yes.
I can hear you. I understand you lost power, but you're dialing in. That's amazing. So I have your case study slide up here. if you would like to speak to that.
Sure. So my focus is in chronic pain. I'm a non-interventional physical medicine and rehab pain specialist. And this was an older study, and we're a little off topic with in terms of rheumatoid disease, but I think the crux of the matter is that pain is pain, and it's obviously very subjective. And one of the reasons why the cannabis studies might have shown no effect is because people interpret it differently, and we don't have, specific dosing to know what the threshold is to suppress pain. It's very individualized, and as I think most of you know, the adverse effects of the products that exist now, even with a nice blend like Sativex of both THC and CBD, still we don't know that is a dose effective for specific conditions. And that's the problem when you study pain and use pain as an endpoint for any clinical study. It ultimately comes down to the subjective sense of this. And we'll talk a little bit more about that. I just put together a few slides. And this was an older study, an older case study that just popped up on my on my computer, but it had to do with a very nice fella who was injured in an earthquake in the 1990s and had severe spinal damage. And you can see the results of that being the pedicle, they call pedicle screws into the vertebral bodies themselves to stabilize anything that might start slipping or moving around. And he had there's a 3-level fusion here. That's an extensive amount of hardware. And that can't be fun. He came to me in 2014, interestingly, in Pennsylvania, where there was no medical marijuana available. He was taking opiates at that time, and the opiate dose was what we would consider high. In fact, the CDC would call that a 95 milligram morphine equivalent daily, that's MED, was the combined use of both morphine and oxycodone at the time. And that 95 milligram threshold is said to be at a serious level of risk, adverse effects of actual inadvertent poisoning. So that's an important number to know. His quality of life had obviously been challenged and had improved since he had retired, but he was doing his best, but coping pretty much with the opioids to some extent. By 2018, they did pass the medical marijuana law in Pennsylvania, and he was one of the first patients. I think I probably did certify him, and his perception of pain distinctly dropped. I'm looking at the slide. He did have a drop of a meaningful, more than 50% drop in his VAS, or his visual analog scale, which is sort of a coarse way of measuring individuals' subjective experience with pain, and his morphine equivalent dropped, which is an even more objective measure of saying this must have worked because he is distinctly taking less morphine from 95 milligram to 0 to 20 milligram, and his quality of life was improved. So next slide. Just in general, chronic pain has become obviously an important parameter for understanding where we're going with these medications and why we're studying them and looking for options, especially with the opioid crisis behind us. But clearly, the numbers show a major climb in all age groups, men and women, women even more so than men. And of course, the elderly population is climbing as we age with these conditions, and especially the rheumatoid conditions that Phil talks about so eloquently. So next slide would be good. This is again a 2017 slide from National Academy of Sciences that really was one of the pivotal studies that then allowed the Pennsylvania legislature to approve medical marijuana in 2018. So because of this National Academies study, we have had the ability to prescribe the use of cannabis for certain conditions. In Pennsylvania, there are 21 conditions, and each state has their own list of conditions that you can prescribe. When I say prescribe, I have to emphasize that the prescription of marijuana or cannabis is not like prescribing an antibiotic, where you prescribe a dose that we know is effective against a certain number of bacteria and bugs, and that dose is given in a certain amount of hours, and it's given over a certain amount of days, and the data shows that we can pretty well eradicate a UTI or an ear infection with appropriate dosing in a short period of time, or 10 days, 7 days. That's not the case with cannabis. Prescriptions are given by physicians who certify that the patient has the condition, but we do not prescribe the medication. We do not prescribe the marijuana or the cannabis at the dispensary site. And the patient may then go into a dispensary and talk to a bud tender and say, give me the best stuff on your shelf. And the bud tender is the guy who or gal who comes up with the concoction that they're going to use, and the delivery system. So it's pretty inexact, but the point of this slide was that it has been approved for chronic pain because of substantial evidence, and there's a couple of studies I'll show you. And as well, the most substantial evidence was in spasticity, another clinical condition I deal with that we see in this case in multiple sclerosis, was felt to be particularly helpful. Next slide, Jahan. And these were another set of studies that the National Academy relied on at the time. And there's a fair N here of about 2,500 patients with 28 randomized trials. And they studied neuropathy, cancer pain, and so on. You can see here. And their data, again, showed a conclusion along with the second study, the Wallace study in 2015, that there was a substantial evidence of cannabis. And as Jahan pointed out, cannabis is many things. We're not just talking about one particular strain or product. It might be easier if we did, and that was my read with the RA study, was that they're just all over the place. There's no single or conclusive evidence that any one combination worked any better than others. Avoiding side effects and improving tolerance as well as efficacy is what this is about. But there's no dose response relationship established, but there was evidence that it did seem to be effective for chronic pain. Next slide. This is from, again, a study in the 2000s that showed the anti-inflammatory effect, and I think that's a catchphrase that we would latch onto as clinicians, that hey, this is anti-inflammatory, and then drilling down into which anti-inflammatories and how it works is something that I think was illustrated in part by that nice study. The bottom line is, we'll take this and say you have a chronic condition, it's causing you chronic pain, and we know that This has anti-inflammatory capacity. We're going to initiate this cannabis license for you, and you're going to go into a dispensary, and it's a guessing game from there. We don't know what individuals are getting, and I don't know the exact feedback from the statewide data, but it's not very well collected, to tell you the truth. And that's an issue I think we are all dealing with at this point. We just don't collect enough data, even clinical data, from the materials that are out there at this point. Okay, next slide.
Yeah. And just a quick reminder as we transition to the next slide, feel free to start populating questions into the chat, so we can ask those, answer those, and be sure to stick around to the end. We have a study announcement, a QR code that you can scan to participate in a survey and share with other clinicians. But sorry for the interruption, Dr. Kamen, please.
That's good. Jehan mentioned that this has interactions at the G protein level, because that's how it's brought to bear on the individual, similar to opioids. There are similarities, and there does seem to be a synergism in experimental studies. And the real value in clinical practice, especially at this point in my experience with this, is really in the reduction of dosing, as was illustrated in that little study, that little case study. The endpoint here may not be to eliminate or fully substitute an opioid with a cannabinoid product, but if we can reduce that threshold, that morphine equivalent daily threshold, is going to be impactful, I think, and that will in turn influence legislatures and hopefully influence grants and studies to codify what is the dose disease relationship. Okay, next slide. Should physicians then recommend, as stated here by Humphreys and Sates in 2019, and JAMA article, there's not the same thing. It's not a direct analgesic compound, and as we just said, there's no real clear data or clear signal of what compound might be the most important of all those subsets of the cannabinoids that we know exist within the THC and CBD molecules. So we don't have that relationship, and there are individuals who have suffered worsening pain with cannabinoids or cannabis, and that study is cited here. But again, I temper that by knowing that pain's a subjective thing, and the intensity, the life around, it's called the lived experience of pain, really makes it challenging to say this is absolutely effective for that. And we just have yet more work to do on that. Next slide. Almost done here. So in summary here, the chronic pain issue is always a question. Can we just substitute? Well, the reason that we're in a quandary about it is because pain is both a cognitive process, especially chronic pain, as well as a subjective and an affective process. And this is a diagram from Melzack, and Melzack developed the gate theory of pain. He and Dr. Wall supposedly wrote this out on a paper napkin in the early part of the late 1960s, I think. And this is a step further by illustrating what he calls the neuromatrix of pain. But the time continuum, which you can see on the bottom, goes from it being primarily pain being a sensory experience to being more of a cognitive affective experience in the long run. And as pain becomes a part of the organism's operating system, and they begin to fear the pain and they begin to anticipate the pain, and then magnify the pain by some of their own background fears and affects, that's when it becomes challenging, and that's why it's such a difficult, sometimes a moving target. And that's why we need to look at pain in that cognitive, sensory, affective perspective when we read through those studies. All right, next slide. Or
Dr. Kamen, before we transition, we got an interesting question from a health professional who
Sure.
is asking, is there any evidence of cannabis-induced hyperalgesia?
That's a good question. So what is hyperalgesia is the first part of that response, and that means that individuals seem to be becoming more sensitive to pain the longer they're exposed, and the more they're exposed to, especially to opioids. The doses become higher and higher, and their pain levels become higher. And we've initially attributed that to something we would call tolerance. You become, you're changing your baseline, and you're now able to take more. And that happens in alcohol, it happens in many substances that we imbibe. But hyperalgesia itself is said to be actual reactivation of the glial cell system in the spinal cord. And the glial cells that were formerly felt to be dormant are now exuding nociceptive proteins. And that becomes the effects of prolonged exposure to high-dose opioids. We do not see that in cannabinoids. And again, because the mechanism is different, and yes, there are some similarities, but it is not a direct analgesic. And I do not know of any studies that show hyperalgesia related directly to cannabinoids.
Thank you so much. That's an amazing answer. Moving on. Thank you so much, Dr. Kamen. Everyone who's still on board, stick around. Again, we have a study announcement at the end of this, and some more opportunities to ask questions, populate the chat. But Dr. Malloy has been working on developing some, let's say role-playing discussion topics of how to interact it. So Dr. Malloy, what should clinicians do if a patient walks in and says, "Doctor, do you think I should try medical marijuana for my RA?"
Thank you. The reason to throw this question out on a slide is just not to tell you how to answer it with a patient, but to get you to role play with yourself after this conference is over, or when you're on the airplane next time, because you're going to get asked this question. Patients are not afraid of asking it. I hear this question, as I'm sure do all rheumatologists, on a regular basis. And I have asked myself over the past 5 years, how am I going to respond to this? Knowing that we have limited data. So next slide. I'm open-minded. I'm non-judgmental. I leave politics aside and red and blue states aside, and just say, I believe data and I believe my patients. And my goal is to make the best, as a doctor, my goal is to make the best judgment to help my patient. Next. I think it's really important for us, all healthcare providers, when patients bring up cannabis, to use that as an opportunity to talk about contraindications. I'm not sure how much the public is aware that there are well documented, beyond controversy, there are adverse experiences associated with cannabis use in women who become pregnant or women who are using cannabis at the time of conception. The fathers at the time of conception also. There is negative baggage that is passed on. breastfeeding, juveniles, unstable mental conditions such as poorly controlled anxiety, schizophrenia, and psychosis. Those are absolute, in my opinion, contraindications. I think we have an obligation to bring it up even proactively in women of childbearing age when they bring it up. So the next slide might be one of the last ones. We're used to, as doctors, having our medications that we prescribed, as Len just said. We don't really prescribe cannabis. We recommend that our patients go to a dispensary. It's not like all the diabetes meds, the blood pressure meds, the lipid medicines that are out there that have been well studied, good dose finding, good toxicology, drug interactions. That data does not exist for cannabis. At the end of the day, we have to acknowledge, this is me speaking personally, we have to acknowledge the limitations of what we know right now, the limitations of what we can do for our patients in terms of extinguishing all of their symptoms to their satisfaction. And so we all have different ways. I'm not going to tell you exactly the words I use to patients, but we all have different ways of talking to patients, saying, this is what we know, this is what we don't know. There are possibilities. 50% of patients, as Jayan told you, in some of these studies, stopped it because of lack of efficacy or no efficacy. Substantial amount had side effects. And there are other contraindications. I would throw it out there and pause and listen to my patients and see how exasperated they are, see how open-minded they are, and have an open-ended conversation. That's all I do.
Excellent. Thank you so much, Dr. Kamen and Teresa and Dr. Malloy for your participation. But Teresa, I think it's time for you to
Well,
jump
I
in.
actually have a question because I know that there's a few rheumatologists, on the line, and I don't know if there's anyone on the line that wants to make a comment without going into the chat about anything that you heard. This is a summary slide. I think we have a few minutes just to open it up, right, Jayhan, to see if there's anyone who doesn't want to
Yep.
write something in the chat. I mean, you
If
can
you
raise your
are,
hand.
yeah,
Isn't there a way to
please,
raise your hand?
you can raise your hand or unmute your mic. I understand if you're driving, texting, we do not want you to text your question and drive. That's one of our rules. You're not allowed to do. But if it's easier for you to just unmute your mic and ask a question or use the raise
Right.
hand feature, we will wait for you to respond.
And while we're doing that, do you want to post the survey now?
Oh, that's a great idea. So while we're waiting for your questions to percolate, we have one more poll or quiz, and that is about our next journal clubs. We're going to have another one on March 5th, first Tuesday of the month. And I just wanted to put out there, what future topics would you like us to discuss? We have, DUI and impairment. We have pregnancy, psychosis, and mental health. Or, is it a more niche topic like or I know some people are interested in some of the lesser known ingredients about cannabis. I don't want to influence the vote, but I will, because I am interested in impairment and the DUI issue. I think it's a little bit of everything: science, policy, public health. It really, and it's something you can see in your daily life as you drive around and people are, hopefully not crashing into you. So I think it is a really big issue of the time, and understanding it's important. Pregnancy, I think there's a lot of misinformation and some really wild studies about pregnancy and cannabis out there. Psychosis and mental health, those are been top covered by national newspapers like the Wall Street Journal. If you go to our webpage here that's floating above my head, we have some free blogs. You just log in, get a free account with your email, and we've written about some of these topics already. All right, the poll's been open, and we'll start to close in just a minute. Change your votes now.
Yeah, so Jayhan, I was just going to emphasize that if they go to the website, you can sign up for free membership and then participate in a different way, in a more interactive way, with Cerium, and we will have another open one, right? I think that there's another one planned for March, and then we will have one for European time as well. I think there's Central European time.
We are working on one, and that might be around noon or 2 o'clock East Coast time, so that folks in Europe can join, which would be about their 8 o'clock. So looks like DUI and impairment has edged out the other topics, but feel free to reach out to us if there's a topic you'd like to cover in one of our monthly journal clubs. We are a little bit at the mercy of what is published.
Yeah, we have a question. So yes, if there's another topic that you'd like to have us explore and cover, that we could also consider, right? So we have one from someone saying, any pressing information about cardiac issues with cannabis use?
I'm actually peer reviewing a paper for a journal on this topic right now. I don't want to spill the beans, but there are concerns about people with certain vulnerable populations. Dr. Malloy, Dr. Kane, would you like to speak to the cardiovascular issues? I understand.
Yeah, over the past, it's sort of almost hot off the press topic. Over the past couple of years, there's some original research, more than case reports. And yes, there is a story here. That's the short answer.
Thank you. Yeah,
I would add that there's also similar studies in opioids and cardiovascular complications. So there's no free lunch.
All right, so I think the last slide, Jehan, we'll just move to that because we partner with a number of different groups. This is a registry, a rheumatology for patients with rheumatoid arthritis, lupus, psoriatic arthritis, all different types of rheumatic diseases, and they are looking for healthcare providers who actually work with patients and rheumatic diseases. If you could scan this QR code and complete this knowledge and attitudes questionnaire, or pass it to someone who you may know who is a healthcare provider, a rheumatologist. And I really appreciate everyone attending and staying on for the duration. Any remaining questions or comments? Now's the time to do it. All right, we'll give everyone a minute to scan that QR code. And lastly, I guess the other thing that I'll pitch, which we don't have a slide for, is that we're collecting. We've been collecting, doing a pilot and that's also on the website, for unwanted experiences or unexpected experiences that consumers have with cannabis and cannabis-derived products, and that's at the www.budsinfo.com. If you're curious about that, or if you want to share that with any consumers about something that may have happened that they didn't expect would happen using a product. So Jehan, anything else?
Not at the moment. Just reminding people that we do have free and paid memberships at the PRC Plus website, and just encourage you to check it out. We will be right about a number of topics on our blogs there, all about scientific articles or things that are talked about in the news. And we're going to be scheduling more of these, so you can check the website for our events, and get in touch with us if there's a topic you'd like to cover. Teresa has a number of clinicians in her network with a number of great backgrounds, as you've seen tonight with Dr. Malloy and Dr. Kamen. So if there's a clinical topic you'd like to discuss, we'll find a paper and we'll bring it to you, and you can join us. So thank you so much. And again, we also like to thank our colleagues at Forward for providing us with the ability to share this study. So please share, reach out. There's so much to learn about cannabis. We need to gather a lot of information. And docs, I don't know if you have any closing statements, clinical pearls of wisdom, or
my comment is, you never know when the power is going to go out. So I'm glad I had a laptop all charged up.
Excellent.
But
Thank you.
this has been a fun and I think intriguing event. I appreciate the opportunity to participate.
Thank you so much.
Yeah, no, thank you both. Thank you all. Thank you,
Yeah.
Dr. Kamen. Thank you, Dr. Malloy. Thank you, Dr. Marcoux, for being part of, PRC Trials Plus. I really appreciate each of you. Thank you. And everyone who attended. Thank you so much for staying on and contributing with your questions and comments.
Thank you so much. It was great questions. All right. I guess we'll see some of you
Time to
next
close
month.
out the room. Yep.
All right. All right. Wonderful. Bye for now.
Bye now.